If you go out and ask one of these conventional providers, you will likely get a response that is just regurgitating stuff that we've heard for years about how oral estradiol is dangerous and it's the devil and you never want to give it to women. It's not a bad thing and it can be very helpful. What we have seen in the randomized control trials is in fact that it seems oral estradiol has even more beneficial effects on bone tissue loss, cardiovascular disease, neurocognitive performance. It certainly improves lipid profiles, ApoB, and things of that nature. Hey guys, welcome back to the podcast. Nico Misleh here with the Nico Misleh Podcast. And today I'm going to talk a little bit about oral estradiol and why everybody's still so freaking scared of using this stuff for no good reason. And I'm going to show you why that's the case. I wrote an email, a daily email about this. And by the way, if you're in like my Facebook group, you could find the PDF so you can read this yourself. And of course, if you guys want to just shoot me a message, I'll happily answer this. But I wrote a daily email about how oral estradiol does not increase the risk of clots. Okay? It doesn't at all. There is so much misinformation about this out there. It's crazy. And I remember when I first started in hormone replacement therapy and I'm reading about estradiol, it was very confusing to me because you would hear most often that oral estradiol is dangerous. It's not good for women. It can cause clots and strokes and pulmonary embolisms, all these terrible, scary things that, of course, none of us as providers want to do. We don't want to do that to our patients. So it made me start thinking, though, because I was looking at the studies that were basically suggesting that oral estradiol would cause an increased risk of clots. And it was a very small study that was done. And it was kind of more like an observational type of study. But at any rate, it was looking at women who were given transdermal estradiol versus oral estradiol. And what they found in this small study was that some of the women who took oral estradiol had an increased, perceived increased risk of clots. So not realized, but perceived increased risk of clots because we saw an increase in coagulation markers. So I thought that was interesting because, again, it's a signal. There's something going on there, but it was a small study. It was not a randomized control trial. And at the end of the day, there have been randomized control trials done using oral estradiol. And I wanted to look at that source first and foremost, because at the end of the day, of course, these smaller studies, it's just a signal. It might be noise. We don't know for sure. So we need to be able to suss that out. And so I always refer back to large randomized control trials. Again, we all can understand that is the creme de la creme, right? When we're looking at studies and whatnot, that's really what we want to be looking for. And so in fact, I have it pulled up on my computer because I think the results are outstanding. In long-term randomized control trials, and I'm quoting this, okay? So the conclusion in this long-term randomized control trial is giving women oral estradiol, okay, not transdermal, oral estradiol, after, I'm going to quote this, after 10 years of randomized treatment, women receiving hormone replacement therapy early after menopause had a significantly reduced risk of mortality, heart failure, or myocardial infarction without any apparent increase in the risk of cancer, venous thromboembolism, or VTE, aka clots, or strokes. 0. That was out of, this study was done in Denmark, by the way. It was out of 1,000 people. That was the conclusion that we had. Okay. So I'm looking at that study. I remember looking at that study and thinking, this is so fascinating because how do I make sense of this? I just read a smaller study that said that there was an increased risk of clots, an increased perceived risk of clots because it increased coagulation factors. And yet when I'm looking at this other randomized control trials, it's saying, no, that never is actually realized. We don't actually see that. It doesn't actually happen. Well, if I'm a true scientist, so to speak, which I think I am, I'm going to go with the randomized control trial. So if that wasn't enough, let me cite another study here because I just want to kind of bury this this myth. So I'm looking at another study, and this one was done. This was most recently done. So the one I was just referring to, it was a great study. Randomized control trial was done in the 90s. Okay. Now, a lot of people would say, oh, that's too old. Well, I mean, we don't get a lot of randomized control trials out of hormone replacement therapy. And by the way, that was a very well done study. But okay, I'm hearing you. Let's look at something from 2022. Okay, so I'm going to this study. It was done in 2022, and I'm going to give you the exact quotations here because this is, I think, so powerful. Here's the quote. During the 12-month treatment, now I like this one because they did full hormone replacement therapy. You should never just give estradiol alone. I really mean that. I don't think that's a good idea. There may be some very, very small, minor circumstances where that might be necessary. So I'll never say never. But in general, you never want to give just estradiol to a female patient. It should always be combined with progesterone. And this is important. I'll get to a second here. But again, I'm quoting, during the 12-month treatment with 1 milligram of estradiol, bioidentical estrogen, or estradiol, and 100 milligrams of bioidentical progesterone, there were no clinically significant differences in blood coagulation parameters, such as antithrombin activity, protein S level, partial thromboplastin, activation time, prothrombin time, fibrinogen concentration, and prothrombin index, 0. This was done by Bukowska et al. 2022. Okay. Pretty dang recent. So 2 randomized control trials are showing that. 2. There are no increased risks of clots, no increased risks of coagulation factors at all. There was a small study done that suggested that transdermal did not show any increase in coagulation. Okay, it was a small trial. Maybe some of the women did briefly. Maybe the more important factor was, did you have progesterone on board, which counteracts a lot of the quote unquote pro-inflammatory cascade types of effects that estradiol produces. So again, there's a lot of nuance there. That is one of the things that, again, I'm just speaking off the cuff here, that I could surmise or hypothesize around as to why didn't it show up in the randomized control trials and only in this weird, small, tiny observational study? I don't know. But what I need you to know is that definitively you can hang your hat on this, guys. In the randomized control trials, the most powerful studies we've ever done on oral estradiol, we have never seen an increased risk of clots. By the way, that last study, the first study in 1990, we didn't see any risk of cancer either or cardiovascular disease risk, none. Now I get that was in early menopause. Fair enough. But all I'm saying is that we didn't see any of those risk factors that we are told that we see time and time again. Now, if you go out and ask, and I'm not disparaging any of my endocrinologist buddies or OB-GYN buddies or primary care, whoever, and I don't care if you're a doc or a nurse practitioner or PA, I really don't. But if you go out and ask one of these conventional providers, maybe they studied at Harvard, right? Johns Hopkins. If you ask them these questions, you will likely get a response that is just regurgitating stuff that we've heard for years and years and years about how oral estradiol is dangerous and it's the devil and you never want to give it to women and it can cause so much more risk. And why wouldn't you just give transdermal estradiol? It is because oral estradiol also has a net benefit. Oral estradiol, yes, it does go through first pass metabolism through the liver. It does. It can increase CRP, which is an inflammatory marker, and it can increase sex hormone binding globulin, which binds up more of your hormones or testosterone. And the SHBG thing is not a big deal. Why? Because most of our women are getting testosterone, and it's going to help lower that SHBG. At least all of them should be. If you're not giving your female patients testosterone of some sort, you're really missing the mark for them, unfortunately. Don't do that. Please don't do that. Give them some testosterone. Help them lower that SHBG. God forbid if it increases that much. If it increases so extraordinarily, of course, I'm not opposed to transdermal estradiol. It's not a bad thing, and it can be very helpful. But what we have seen in the randomized control trials is, in fact, that it seems oral estradiol has even more beneficial effects on bone loss, I should say, cardiovascular disease risk and outcomes thereafter. It seems to have benefit on neurocognitive performance. It certainly improves lipid profiles, ApoB, and things of that nature. Oral estradiol does. Transdermal estradiol does not. At least from what we can tell from the literature, not nearly at the rate oral estradiol does. So the first pass metabolism, even though we think about it in our heads, we think about it a lot of times as like a bug, right? It's a problem in the system. It's not. I think probably it's oftentimes a feature. We see that is true with oral progesterone, right? If you have trouble sleeping and you're a menopausal female and I give you sublingual progesterone, it's not going to do anything. You'll get great levels of progesterone, sure, but will you get enough allopregnanolone, the metabolite of progesterone, which is significantly produced via the first pass metabolism of progesterone, oral progesterone, not sublingual? No, you won't. That only comes with oral progesterone. And that is why 99% of the time I'm giving my female patients, and I recommend that my students give their female patients oral progesterone. We want that first pass effect. And what I see in the literature to be true is that we also want that via oral estradiol. I get it because I am a very risk averse person. I really am in many ways. Even though I've started my own business and I have that entrepreneurial spirit, I am quite risk averse, just like you guys are. I think all of us are as providers for the most part, right? We don't want to do harm to our patients. Of course not. And worse, we certainly don't want to ruin our entire career over a poor decision or a decision that wasn't grounded in any scientific evidence or literature. But folks, this is what I'm trying to say is it is grounded in scientific evidence and literature. It has been for 30 plus years. And it just increasingly is becoming more and more grounded in that literature. So I am asking you and pleading that you let go of some of these, what we would call, right, cognitive biases, these things that you just think of all the time that are dangerous and bad and scary because we were told by somebody or some organization that it was, and yet we never took the time to really look into it. And that's why I created HRT University, because a lot of people have really good questions, not dumb questions or stupid questions. They have really good questions. The amount of times I've been asked, Nico, is oral estradiol safe? My gosh, I'd be a bazillionaire if I got a penny for every time someone asked me that question. But I'm laughing because I love that question. I really do. I love that question. It is not a dumb question. It's a great question. You know why? Because I know what you're thinking. You're thinking there's something off about this. There's something I don't know enough about, and I feel like I haven't been told the right answers, and I'm seeking that. And I love that. You're my favorite type of person because you know that something's off, and you're actually in a position of saying, you know what? It's not about me and my feelings. It's about my patients and their health and wellness. That's what makes a great provider. It's not about our feelings. It's about the patient's health and wellness. I feel scared about giving women oral estradiol. Okay, I understand that fear. Let me give you the rationale, the reasoning behind why you don't have to feel afraid about that anymore. Okay? And in the human world, we need that. We need proof. We need evidence. The only thing we don't need that with is between you and God. Okay. God doesn't need to provide us any of that stuff. For human beings, absolutely. It's critical. And I'm going to provide that to you through all the amazing researchers and physicians and medical providers before us who have come up with this great body of literature. Let me distill that information for you, just like I did today, so that you can feel confident. You can let go of some of that imposter syndrome crap and just get to the good stuff, which is treating your patients and helping them have lives that are just so unbelievably good that they want to pay you in beautiful green dollar bills. Okay. And you're not going to feel ashamed about that because they are happy to give you money because you've made their lives significantly better and they're going to live longer and more purposefully. That's a dream, right? So, is oral estradiol dangerous? Does it increase the risk of clots or strokes or heart attacks or any of that stuff? No, it does not. It seriously does not at all. The randomized control trials say so. Okay. So look at the studies and consider them, please. If you want this article, please let me know. I'm more than happy to send it to you. It's a daily email. Again, it's public on my Facebook group. If you're a part of the HRT, Nico's HRT University Facebook group, if you go to like the pinned featured stuff at the top, and if you scroll over, you'll see it'll say PO, E2, something like that article. Just click on it and download it. It's a PDF. You can keep it for the rest of your life. It has links to the studies. So I'm not just like spaceballing this. It has real links to the actual studies. So you can see that all this stuff is heavily baked into my HRT University course too. So if you haven't taken that already, please dive in, because I will walk you through all the myths and boogeymens that are out there and show you definitively that either they're not true, and if they are true, what do we do about it? Okay. So guys, I hope this was really helpful. Please don't feel frightened. Please feel empowered by this so that you can go make a difference in your patients' lives, get paid really well to do so, and sleep really sound at night. See you at the next episode, guys. Take care.